Hello everybody, good morning. I am Professor Dr. Muhammad Nawaz from Pakistan. I wish I would have been there, but unfortunately I couldn't make it. My topic of today's presentation is CT scan of brain in headache in pediatric age group. Basically, it is an audit study and the learning objective is to determine and assess the appropriateness and the outcome of CT brain for headache in the children. Headache. Almost every child suffers from headache in his childhood. So headache is a very common complaint in children. For the evaluation of this headache, in imaging department, either CT or MRI brain are usually and frequently advised. But special concern with this headache in child is the possibility of intracranial pathology. So we have to rule out intracranial pathology by doing the CT and MR of the brain of the patient with complaint of headache. And to go for CT brain is a very difficult option and decision to make in case where there is no underlying brain pathology. So, for doing CT brain in all such cases who suffer from headache looks like misuse of radiation. But biggest dilemma is that up to 10% of the children with brain tumors may present as cause of headache as the only symptom. So the value of screening is compromised due to majority of children presenting with headache but very low outcome of the imaging. So the appropriateness of imaging should be prevailed by identifying the clinical signs and symptoms that are associated with headache, appear to be useful predictors of positive imaging evaluation. ACRAC, American College of Radiology Appropriateness Criteria, was considered and chosen as the standard for this study. ACRAC is actually a clinical guideline for the appropriateness of various imaging modalities used in the children with headache. ACRC categorized and classify headaches into 5 types. So there are 5 types of headaches according to ACRAC classifications. First, isolated headache which is just not related or associated with any other sign or symptoms. Second, headache with positive neurological signs and symptoms like nystagmus, altered sensation, etc. Means when the headache is associated with some neurological signs like change in the sensations or nystagmus, etc., etc. And third type of headache with sporting historical data like diplopia, vomiting, and imbalance. So headache when associated with diplopia, vomiting, or imbalance in according to the ACRAC, this is third type of headache. So fourth is the acute severe thunderclap headache. When the headache is very severe, intense, this is fourth type of headache according to the ACRAC classification. And fifth and the last type of headache is the common or classical migraine type of headache. When headache is typically associated with classical migraine. So it's so common. There are 5 variants of headaches according to ACRAC classification of headache. So ACRAC appropriateness rating criteria. So on one side there is variant of headache, and on the other side it is appropriateness rating scale of CT scan. It varies from 2 to 9. So when it is least, like 1 is the least, and when it is highest, so in this table 9 is the highest. This means the most appropriate. Isolated headache and common or classical migraine headache scores 2, while headache with positive neurological signs and symptoms and headache with supporting historical data score 8. While thunderclap headache or acute severe headache scores 9, which is the highest in this. Now, this study was completed and conducted in the radiology department of Hayatabad Medical Complex, Peshawar, Pakistan, over the period of 1 year. Standard protocol for CT scan brain was adopted, and age range of 4 to 18 years of patients belonging to both genders, male and female, with history of headache, either isolated or common classical migraine, were included in this study. We scanned 100 patients over the period of 1 year in this study. And among these 100 patients, only 4 showed abnormal findings. All these 4 were suffering from sinusitis. 40% of the patients were below 10 years, and rest means 60% were above 10 years. Male 69, while female 31. So male to female ratio is 6.9 to 3.1. Headache, as we earlier discussed, is very frequently occurred, and it is one of the very common complaint, so frequent in the childhood. Global statistical data reveals 19 to 51% prevalence of headache in these patients. And this is very much comparable to our study in which 40% of the patients were below 10 years. Prevalence rate of headache is up to 85% in the school-going children. 85% among the school-going children. Prevalence of headache was found to be 56 and 74% in the adolescents, boys and girls respectively. Majority of the children with history of headache turn out to be normal in CT brain, or in some few patients there may be some incidental findings that didn't relate specifically to their headache. In a study, this study is very closely comparable to the different studies performed globally. For example, Khan et al. On patients with AR2, 86% showed no abnormalities on CT scan, as compared to our study where 96% had normal scans and only 4% showed abnormal findings. All these 4 patients in our study had sinusitis, very much comparable to the Khan-Ali study. In our study, 4% means 4 patients in our study had sinusitis compared to the Khan-Ali study. In our study, 4% show pathology, while J et al. Reported 3.8% had pathology in his study. As radiation exposure of 90 milligray, which is a big amount for CT head, should be avoided by identifying low risk children. So this is the point. We should identify low risk children from those with high risk probability of intracranial pathology. So this should be avoided by identifying low risk children with isolated or classical common migraine. AR2, our study, sports to this idea of prudent clinical assessment for identification of low risk children. This is the main point, that we should recognize, we should isolate those with low risk children. So the basic idea behind my study is to identify the low risk children from the others. So in the conclusion of this audit study, that multidisciplinary approach of pediatrician and radiologist is must to develop a proper appropriate referral protocol to avoid unnecessary CT studies and a lot of unnecessary radiation exposure. So the basic point is just appropriate proper referral protocol by a multidisciplinary committee of radiologists and pediatricians. So, just to avoid unnecessary CT studies which causes lot of radiations 90 milligray to the children in 1 CT head. In this respect, a local clinical practice guideline will augment in the identification and priorities of high-risk children, which will not only reduce the workload of CT in radiology department, but also avoid unnecessary extra radiation exposure to the children. So, in the last take-home message, the radiation should be principally as low as reasonably achievable. So, before sending the patients in pediatric age group for CT brain, we should screen out the high-risk children from the low-risk children having SOL or intracranial pathology from each other. So, radiation should be as low as reasonably achievable. So, this is the take-home message. Alara. Thank you. Thank you for the patient listening. Thanks.